Now, coming to what are the techniques to increase the denuded root surfaces? Techniques used for root coverage procedures. Fine. So, there are two ways. One is pedicle graft, another one is free soft tissue graft. By this time, it should be very clear that pedicle, a tube or a stem of tissue, remains attached to the donor site, right? So, pedicle graft are again classified as rotational and advanced flaps. Rotational and advanced flaps. So, the rotational flap, I am just rotating it from the adjacent side, right? So, laterally positioned flap, transpositional flap, double papilla flap. So there are three rotational flaps. One is laterally positioned flap, transpositional flap, double papilla flap. So laterally positioned flap is nothing but I am just pulling it laterally and I am just suturing it. Okay. Next one is advanced. In this, I am advancing it. Okay, I am bringing it upward. Okay, so advanced flaps. Name indicates coronally advanced flap, semilunar coronally advanced flap, bridge flap. Okay, so these are all the pedicle graft which we are going to discuss. Okay, so pedicle graft, it has rotational, advanced. In the rotational, we will be talking about laterally positioned flap, transpositional flap, double papilla flap. In the advanced, we are going to talk about coronally advanced flap, semilunar coronally advanced flap or semilunar flap, and bridge flap. These are all the pedicle graft where I'm not going to cut the entire tissue. Either I'm going to move it laterally or coronally. Okay, that fulfills the definition, right? Stem or a tube of tissue remains attached to the donor cell. Now, coming to free soft tissue graft. Free soft tissue graft can be free gingival graft and connective tissue graft. Okay, it can be FGG or CTG. It can be FGG or CTG. Free gingival graft and connective tissue graft. So these two are free soft tissue graft wherein I'm going to completely detach that piece of tissue and I'm going to place it at the recipient side. So the donor tissue, the tissue completely detaches and it is placed at the recipient side. That is going to called as free soft tissue graft. If it is attached, then becomes pedicle graft. Okay, fine, very good. Now we are going to move to the laterally positioned flap. Okay, as the name indicates, there's going to be an isolated area of recession. I'm going to move the adjacent gingiva to this area. One, there should be adequate width of keratinized gingiva to perform this procedure. Okay, one is there should be adequate width of keratinized gingiva, because what happens if the adjacent tooth itself is compromised? You are taking a gingiva from a compromised tooth and placing it, means that is worse, right? So the tooth or the gingiva from where you are going to displace it laterally should have adequate width of keratinized gingiva, and this technique can be done only for a few teeth recession. Okay, and this technique has a very less success rate. Okay, this technique has very less success rate. And if you take a look at the advantages of this technique: good vascularity, good color matching, and one surgical site. This will go for all the pedicle graft, one surgical site, right? So the laterally positioned flap was given by Group and Warren. The laterally positioned flap was given by Group and Warren 1956. Okay, so there should be adequate width of keratinized gingiva, and it is used to treat only a few teeth with recession, decreased success rate, and there should be good vascularity, good color matching. There will be good post-operative healing as there is only one surgical site involved. Patient compliance will be good, right? So moving on to the technique, we'll see how it is done. Okay, first what they will do is, any root coverage procedures, what they will do is, they will just remove the epithelium. Okay, they will just remove the epithelium so that the graft which we are going to place receives the nutrients from the connective tissue. The epithelium does not have blood supply. How does the epithelium survive? Epithelium survives by the process of diffusion, the diffusion of nutrients from the connective tissue. That is how the epithelium survives. So when I'm going to move adjacent gingiva to this area, I'm going to remove the epithelium. That is what we are going to call that as de-epithelialization. Okay, so what I will do is, I will just remove the epithelium with the help of a blade, and it will look something like this. So once I remove the epithelium, it will be very red, which is nothing but connective tissue. So now this is called as, the site which receives the treatment is called as recipient site, and the site which gives the gingiva, or the gingiva from where the gingiva is pulled, is called as a donor site. So the recipient site is now ready for receiving the graft. So first thing is, I should do, first and foremost thing what we should do is thorough root planing, root biomodification agents. The root should be smooth and clean, which is followed by de-epithelialization. Okay, and then which is followed by incision, especially full thickness mucoperiosteal flap. Okay, I'm going to give a full thickness mucoperiosteal flap. Okay, so once the full thickness mucoperiosteal flap is elevated, okay, it will look something like this. And then what I'm going to do is, I'm going to pull it laterally, and I'm going to cover the area of the recipient site, and I'm going to suture it off. Okay, clinical images. A patient with isolated area of recession. Okay, patient with isolated area of recession. I'm just removing the epithelium, as you can see here. This process is called as de-epithelialization. Why it is done? Mainly to expose the connective tissue, and initially the graft survives with the help of plasmatic circulation. Okay, we will talk about what is this plasmatic circulation when I talk about healing of the soft tissue or pedicle grafts. Okay, so areas de-epithelialized, and I'm giving a vertical releasing incision here. Okay, and I'm giving a vertical releasing incisions, as you can see here, the vertical releasing incision. Okay, so once the vertical releasing incision is given, a full thickness mucoperiosteal flap is elevated, and it is sutured to the recipient side. So now you use your common sense and tell me what might be the complications of a laterally positioned flap. Very simple. I am raising a full thickness mucoperiosteal flap, and I am pulling it to the recipient side. What will happen to the donor side? Obviously, it will be exposed with bone, right? If at all there is poor wound healing, if the patient is not maintaining well, there will be formation of fenestration or dehiscence. There will be formation of fenestration and dehiscence. Okay, if the patient is not maintaining well. And you see, look at this one, there's increased tension, pull it with much force, there's going to be retraction of the flap. Now, by this time, you should know how to prevent this excess tension. What incision you will give for extensive flexibility or to prevent the excessive tension. Excellent. Cut back or releasing incisions. Cut back incisions. Cut back or releasing incisions is usually given to prevent these kind of excessive pressure, right? So what I'll do, I'll just give an incision here, so it moves easily, right? So you take a look at this one. So the flap is extremely narrow, it's thin, so it's going to get detached or it's going to degenerate over a period of time. Fine. And this one is what I was talking about. This is fenestration and dehiscence. So since you are raising a full thickness mucoperiosteal flap, there are chances of fenestration and dehiscence at the donor side. Fine. Very good. So these are all the few incision techniques which was followed earlier. So this area, they are deepthalize, give vertical releasing incisions, move forward. Similarly, there is a small change in modification of the incision here, and you see this technique is given by Kohn, a cutback incision in 1964. This was given to prevent the excessive tension. Okay, fine. So moving on to the next technique, which is nothing but transpositional flap. Okay, transpositional flap, as the name implies, it is a slight modification of laterally positioned flap. Okay, it is a slight modification of laterally positioned flap. Okay, so transpositional flap is a modification, is a slight modification of the laterally positioned flap. What is that modification? Very simple. As I told you earlier, you see here, there is a full thickness mucoperiosteal flap which is reflected and it is moved here, right? The full thickness mucoperiosteal flap is moved to the donor side. Instead of the full thickness mucoperiosteal flap, in transpositional flap, they are giving split or partial thickness flap even in the donor area, right? It looks something like this. So I'm just removing the epithelium over here. Okay, I'm giving vertical releasing incisions, and instead, see beautifully, instead of the full thickness flap, I'm just releasing a split thickness. As you can see here, split thickness, there is connective tissue which is attached to the bone, and I'm suturing it at the donor site. So in this way, I'm going to prevent the fenestration and dehiscence. Okay, but again, because you are not raising a full thickness mucoperiosteal flap, there are chances of flap failure, flap retraction. Too thin a flap, it will result in degeneration. Okay, so transpositional flap is a modification of laterally positioned flap wherein they raise partial thickness flap instead of a full thickness flap from the donor side, and they suture at the donor side. So clinically, as you can see here, a patient came with gingival recession, so I'm just deepitalizing this area. Okay, deepitalizing this area, and what I'm going to do, I have given vertical releasing incisions. I'm just raising a split thickness flap, moving it to the donor side, suturing it off. Simple, right? But again, since I have to raise a split thickness flap, it is technically demanding, it is technique sensitive. If I don't handle the flap properly, then that might result in tearing of the flap. Okay, excellent. Now, coming to double papilla flap. So, double papilla flap is nothing but it has a few advantages. Okay, since the papilla is extremely thick, there is going to be good blood supply. Okay, and disadvantage, again, there's going to be full thickness flap elevation, fenestration, dehiscence, and it cannot be used for multiple recession. Your transpositional flap can is also cannot be used for multiple recessions. Okay, so all these three will come under rotational flap, laterally transpositional double papilla. So if the area of the recession is this, then I'm going to take this papilla and close this defect. That is called as double papilla flap technique. Okay, so this technique cannot be used for multiple recession, and also there should be adequate length and thickness of interdental papilla to do this technique. Okay, so the technique will look something like this. So there is a recession in this area. What I'm going to do, I'm going to take these two interdental papilla, okay, and I'm going to raise a full thickness flap. Okay, raise a full thickness flap, and I'm going to suture the area, the final image will be like this. As you see here, there is going to be exposure of the bone, and if the patient does not maintain properly, that might result in fenestration and dehiscence. That is one of the drawbacks of double papilla flap. So the double papilla flap, even though it has an advantage of the thick internal papilla and there is good vascularity, because there is elevation of a full thickness mucoperiosteal flap, there are chances of fenestration and dehiscence at the donor side. Fine, it cannot be used for multiple recession defects. So there should be adequate length and width of the internal papilla to perform this procedure. Excellent. So this will be the clinical picture. So as you can see here, there is a recession, and I'm giving two vertical releasing incisions, and I'm going to raise a full thickness mucoperiosteal flap, suture it, and post-operative image. Okay, again, the causes of failure: too tight the flap, tension, increased tension, failure; fenestration dehiscence, failure; if the narrow flap, failure. So these are all the few causes of failures of the double papilla flap, right? So now we are going to talk about coronally advanced flap. So coronally advanced flap was given by Bernie Moulin. Okay, so coronally advanced flap is very important, because coronally advanced flap, CAF means coronally advanced flap, plus the connective tissue graft is the gold standard for recession coverage, or root coverage is a gold standard for root coverage. Okay, so coronally advanced flap with connective tissue graft is a gold standard for root coverage. This is the first one that treats multiple recession defects. And there are two variations of the coronally advanced flap, of which one does not have vertical releasing incisions, and that can be used for aesthetic purpose. Okay, and the important requirement for this is the width of keratinized gingiva should be more than 3 mm. The width of keratinized gingiva should be more than 3 mm. That is one of the main requirement of a coronally advanced flap, and it is technically easy, and it has an high success rate. It has an increased success rate compared to laterally positioned flap, which has a decreased success rate. Okay, now this is a first modification of a coronally advanced flap. Very simple. Okay, so horizontal incisions were given at the level of CJ. Okay, and then vertical releasing incisions were given, and a full thickness mucoperiosteal flap was elevated. It is pulled coronally and sutured. Very simple, isn't it? So horizontal incisions at the level of CJ, and then I'm raising a full thickness mucoperiosteal flap, and I'm suturing it coronally. This is another modification of coronally advanced flap. Here I am not going to give any vertical releasing incisions. I am just going to reflect the flap, give periosteal releasing incision, and suture. What is periosteal releasing incision? Periosteal releasing incision is given at the base of the flap to pull it coronally. Okay, so as you can see in this image, what is this represents? This represents the direction of incision. Okay, why it is different in various tooths? Very simple. Any incision which is given in coronally advanced flap should follow or should converge towards the tooth to be treated. So here this is the target tooth, right? So all the incision should follow this. This should be like this, like this. This should be like this should be like this. Now it becomes easy, right? So any incision should follow the tooth to be treated. That is why they are given a few directions. Okay, don't get confused. Now I'm raising a full thickness mucoperiosteal flap and I'm suturing it coronally. That's it. So the coronally advanced flap along with the connective tissue graft becomes the gold standard. Bernie Mowley, 1965. Semilunar coronally advanced flap was given by Tarnow. Okay, semilunar coronally advanced flap is, it's a very simple procedure. It's a very simple procedure. It basically believes in gravity. Okay, so it uses split thickness flap, and it cannot be used for, or it is very difficult to use it for multiple recession defects. Very difficult for multiple recession defects. And it can treat recessions of only of 1 to 2 mm of recession. Okay, technique very simple, very simple. See, take a look at this case. I'm giving a small semilunar incision. I'll erase it now. Okay, as you can see, there is a small semilunar incision. You can see here, right? Excellent. So what I'm doing is, I'll be giving a small semilunar incision, and then what I will do is I will insert the blade into the sulcus and do a split thickness dissection. As you can see, my blade coming out, right? So this is a split thickness dissection, and once that is done, I'll just pull this to cover the defect. At this point, either I can suture, put an anchor suture, or I can keep pack and believe in gravity. You can suture, pull it down, or you can just place a pack and believe in gravity. Either way you can do. So this is a very simple procedure for root coverage. It's a semilunar coronally advanced flap technique. Okay, very good. So this is a semilunar which was done in multiple tooth. Again, it is very difficult to do a semilunar coronally advanced flap for multiple tooth defects. Okay, fine. Now coming to bridge flap. So bridge flap is very simple. I'm going to give a small, just a minute. I'm going to give a small incision in the vestibule, as you can see here. So I'm going to give a small incision in the vestibule, and then what I'm going to do is, I'm not going to break the papilla. I'm just going to give incision only in the sulcus, and then I'm going to pull it forward, raise a full thickness flap like tunneling. I'll just give a circular incision, put my periosteal elevator inside, just reflect the flap, full thickness flap, pull it coronally. I'm not going to break the internal papilla. I'm just going to give circular incision, raise a full thickness flap, suture it coronally. This is called as bridge flap. Okay, so the pedicle graft comes to an end. Okay, so what are the pedicle graft? Rotational advanced. Rotational flaps are laterally positioned flap, transpositional flap, double papilla flap. Advanced flap are semilunar flap, Tarnow, that is coronally semilunar coronally advanced flap, and bridge flap. Okay, so all these are pedicle graft, which means I'm not detaching the tissues. I'm just putting it laterally, coronally, or something like that. Okay, so the next one will be the free soft tissue graft.